But there's things. So yeah. All right. Well, thank you everyone for joining us. Hopefully folks can hear me on WebEx. But I just want to thank everyone for coming. It actually feels a little bit nerdy where I don't get to say like hello and say everybody's name like I do when we're doing Hollywood Squares. And so, but it's lovely to actually be doing this in hybrid. So welcome everyone to our combined adult and pediatric palliative care All Hill Grand Round series. It's really, really fantastic to be able to host a guest speaker today, and really thankful to Dr. Stowers, the Center for Ethics in Healthcare, for hosting the Brill speaker for this year and having us the opportunity to have Dr. Sanders join us for palliative care grand rounds. But I wanted to just take the opportunity to welcome everybody to our grand rounds lecture series, and I will hand it over to Dr. Stowers to introduce Dr. Sanders to the group today. So Katie, please.
Fantastic. Hi. Thank you all so much for joining, both virtually and in person. As Jason mentioned, it is really lovely to be meeting in person again, and also so glad for our technology to be able to connect with those who couldn't be here in person. We do have lots of good and bad sugar over here on the side, so please come help yourself. I am super excited to be partnering with the Palliative Care Grand Round series and the OHSU Center for Ethics to bring Justin Sanders as our Madeline Brill Nelson speaker. Many of you have had an opportunity to meet with Justin during his 2-day visit here, but I'm going to give just a brief introduction, which Justin can fill in when I'm done. But Justin is an associate professor in medicine, in family medicine at McGill University in Montreal. He is the Kathleen Aaron M. Flanders Chair in Palliative Care Medicine and the Director of Palliative Care. After completing family medicine residency and palliative care fellowship, he did a research fellowship with the Ariadne and is now doing both research and leadership at McGill University. And his research focuses on understanding and implementing interventions to improve both the care and the communication equity for both patients and clinicians. Patients affected by serious illness, and clinicians, I was going to get that. So we are super excited to have you join us. It has just been a fantastic, what seems like longer, but I guess 24 hours that you've been here hanging out with us.
Yeah.
Lots of connections, lots of learning, and super excited to hear what you have for us today. So thank you.
Well, thank you so much for having me. Thank you, Jason. It's been a real pleasure to be here. So yeah, and I think much will come out of this visit in terms of collaboration and other good things. So I'm really grateful for the opportunity to come. I also love Portland, so it's great to be here. There's 2 things you should probably never do when you start a Grand Rounds talk, which is give an apology and a caveat. But I'm going to give an apology and a caveat. My apology is that some of the things that you'll hear today are similar to what I talked about yesterday in my Grand Rounds for medicine. And the caveat is that I use some of the same stories in service of a sort of deeper picture and a slightly different end. So I hope you'll be patient with me in that way, and that the stories don't seem boring to you. They certainly inform a lot of my thinking about my work in palliative care, and I've done a lot of thinking about how these ideas can contribute to sort of come from the past and can contribute to the future of palliative care. So. Yeah.
Despite our best efforts, your hand is about 90% of my life. So I'm thinking maybe I should switch.
Oh, okay.
Or just scooch on down. There you go.
Is that okay?
You are much more Wesley now. There we go.
So I'd really like to share with you a vision for the future of palliative care. And indeed for the future of medicine. So that's what I'm going to get started to do. I will say that my clicker isn't working. I have no financial disclosures or conflicts of interest. I will say again that I think it's important to mention that I am a white, cisgendered, able-bodied, heterosexual, middle-class, married male palliative care physician and researcher and a father of 2. And I currently live in Canada, even though I'm American. And I think it's really important to mention these things because these are the lenses through which I view the world. I can't help that, but I can try my best to try to see around them in some ways. And something I try to actively do. And I think the only way that we can do that is by recognizing sort of places from where we come. So that's where I come from. My objectives are to describe, at the end of this, you'll be able to describe 2 central constructs relevant to the history of palliative care practice, to distinguish between the relief of suffering and the promotion of healing as independent aims of palliative care and in fact all of medical practice, and that you'll be able to integrate strategies that promote the recognition and promotion of authentic healing relationships in medicine and in palliative care. So as I said, I want to talk with you about the future of palliative care. And I begin with this phrase, what's past is prologue, whose common usage suggests that history sets the context for the present, and the past might or should somehow determine our future. And I hope to make the case that healing relationships, which are fundamental to the philosophy and practice of palliative care as it took shape, and are yet now only kind of peripheral in our field of view, deserve renewed attention as a driver of the highest quality healthcare. Healing relationships are not only of quintessential importance to those who are affected by serious illness, patients and caregivers, but they're also key to the sustainability of our healthcare system and those who work in them. And I think that the urgency of these relationships has never been greater because we face an aging population, a related rise in the incidence of serious illness, and really what I think most of us are recognizing is the greatest workforce crisis in the history of medicine. So what's past this prologue is the line from William Shakespeare's The Tempest. The Tempest, as many of you know, is the story of a magician, Prospero, the deposed Duke of Naples, who's lived on an island in the Mediterranean with his daughter Miranda and his slave Caliban. And Prospero uses his magic to conjure a storm that shipwrecks the king of Naples, Prospero's brother, Antonio, Sebastian, the king's brother, and Ferdinand, the king's son. Thinking that Ferdinand is dead, Antonio engages Sebastian in a plot to murder the sleeping king and usurp his throne. And by the destiny, Antonio says, to perform an act whereof that's past his prologue, what to come, in yours and my discharge. Now, while much drama ensues, the royal family is united in the end and resolves their disputes. And to me, The Tempest provides a compelling reference and a metaphor in this moment, because while we continue to feel its tailwinds, we've all just passed through a great storm of a once-in-a-lifetime pandemic, once-in-a-century pandemic, and been deposited together in a somewhat new and unfamiliar place, one in which past and present injustices have revealed themselves in greater clarity. We have, for example, been forced to confront a history of racial injustice and its impact on the lives and well-being of those whom our systems continue to marginalize. And the metaphor of a storm also seems apt for the experience of serious illness, in which one is unmoored, tossed about, uncertain of what will come and when. And to have weathered this storm may serve as a metaphor for healing. So the prologue is also what typically sets the scene for a play. So what's past this prologue can be interpreted more specifically in The Tempest to mean that what has already happened merely sets the stage for the important things to come. And for Antonio, the things upon which his and Sebastian's greatness will depend. In full, these words give prelude to agency, what to come in yours and my discharge. I believe that this agency is ours, and that a clear view of the past will give direction to our future action. And because this talk is about the past and future of palliative care, and because palliative care concerns itself with those affected by serious illness, I'm going to be speaking about 2 constructs that are of central importance to people affected by serious illness: suffering and healing. So I would like to start by telling you, again, for some of you, a brief history of palliative care and its lead characters and central themes. And this history highlights the dual importance of suffering and healing in the development of palliative care. And I'm first going to start off by telling you again a story about me. As some of you saw yesterday, this is a grainy photo of me asleep on the couch. It was not long after this photo was taken that I was woken with some urgency to come help reposition my friend Melissa, who was dying of ovarian cancer. Melissa was in fact my best and oldest friend. I think we were 4 or 5 in this photo, and we were 21 when she died. It was a Saturday morning. I'd been told that she would die on Tuesday when I was across the country at university in Pennsylvania. And I didn't think that I'd have the chance to say goodbye. I sat on my apartment step in the autumn sun on a day very much like, a little bit like today, and wrote her a letter to say that it was okay to let her go. Hers had been a journey of a long 3 years. And so I flew to Los Angeles on a Friday, and Melissa was still alive. And despite the warm air and an open sunroof, I was tense on the ride from the airport, thinking that she might die while I was on the last leg of my journey. And I arrived to find her perched up in bed, pregnant with tumor, surrounded by lit candles and soft music. And over the next several hours, I and 2 other of Melissa's closest friends sat on her bed, traded memories, laughed, held her hand, and even made a show of trying on her whole collection of hats that she'd accumulated over the years. And despite Melissa's severe pain and fluctuating consciousness, these hours were full of joy and meaning. I stayed up with her through the night, helping the nurse draw and give syringes of fentanyl to ease her pain, and then I fell asleep. As I said, I was awoken with some urgency and entered the room to find several people trying to move her from a chair back to her bed. And there was a shift in the air. Somehow the room emptied, or at least it did so in my mind, and it became clear that Melissa was in fact very close to death. I sat with her, holding her hand. Her grandmother held the other, offering what I hoped were comforting words about butterflies could carry her away. And she took her last breath. That her parents were not there, they were in fact in the house but could not face this moment, was evidence in my mind of the need for palliative care, which they were never offered and which I didn't yet know existed. What I recall leaving her room was an uncomfortable sense of elation, of awe even, a feeling that I had taken part in something important. That Melissa, though dead, was also in some way healed. So the history of palliative care begins with this remarkable woman, Cicely Saunders, later Dame Cicely, trained as a nurse as part of a patriotic response to World War II, and then as an almoner, what we think of now as a clinical social worker, and then remarkably for the time as a physician. She was struck in her earliest work by the needs of the dying and our inattention and expertise in caring for them, inexpertise in caring for them. And in each of the early stages of her career, she drew insights that would shape her aspirations and vision for a place in which those who were dying could find the best care. Since she would write of her early experiences caring for people with cancer, we really had nothing to offer but ourselves and meticulous nursing. So that really made me realize how important relationships are in any medical sphere. Through her care of the dying in various institutions across London, Dame Cicely would come to articulate one of the fundamental constructs in palliative care, total pain. And in an article from 1964, she described the experience of a patient for whom she cared at St. Joseph's Hospice in Hackney in East London, who said, "Well, doctor, the pain began in my neck, in my back, but now it seems that all of me is wrong." She would use this phrase to capture the multidimensional nature of suffering, the physical symptoms, mental distress, social problems, and existential emotional torment that characterize for so many the experience of dying. That the experience of pain of one sort is compounded and reinforced by other forms of distress may seem obvious to some of us. But at the time, and to many, this was actually a source of some controversy. In contrast to the pain from a surgery, whose meaning was clear and whose end could be anticipated, the pain of end-stage cancer was one that seemed open-ended in its length and severity, a situation, she would write, in which you're absolutely held. Total pain is an important construct, not just because it offered a more sophisticated lens through which to view the experience of serious illness, but also because of what it meant for how we approach people, we care for people at the end of life. It necessitated a multidisciplinary approach embodied by Dame Cicely herself, in which we could only and best attend to the multiple dimensions of suffering using a collaborative model of care involving physicians, nurses, social workers, pharmacists, chaplains, and volunteers, and others. And so to what did Dame Cicely look for the relief of pain? It was not a 1 or a 2 on a visual analog scale, in fact. Vital signs in a ward specializing in the control of terminal pain, she would write, include the hand steady enough to draw, the mind alert enough to write poems and play cards, and above all, the spirit to enjoy family visits and spend the last weekends at home. In the early 1970s, a urologic surgeon at McGill University named Balfour Mount found that he too was struck by the importance and possibilities of caring for those who were dying. And in his encyclopedic memoir, 10,000 Crossroads, published in 2021, he describes a mesmerizing 1972 lecture by Elizabeth Kubler-Ross. Many of you are familiar with, a Swiss-American psychiatrist working in Chicago, in which she described her work learning from the dying about their experiences. Not long after, he was asked to chair an adult education meeting at his church on death and dying. And they read an anonymously written piece entitled Death in the First Person, in which a nursing student wrote, "I am dying. I write this to you who are and will become nurses, in the hope that by sharing my feelings with you, you may someday be better able to help those who share my experience." This person went on to describe the coldness with which they received care in the hospital, and then write that the dying person is not yet seen as a person and thus cannot be communicated with as such. He is a symbol of what every human fears and what we each know, at least academically, that we too must someday face. The writer continued, "I know you feel insecure, don't know what to say, don't know what to do, but please believe me, if you care, you can't go wrong. Just admit that you care. That's really what we're searching for. All I want to know is that there will be someone to hold my hand when I need it." If only we could be honest and both admit our fears, touch one another. If you really care, would you lose so much of your valuable professionalism if you even cried with me? Just person to person. Then it might not be so hard to die in a hospital with friends close by. Dr. Mount, or Bal, as he is known to friends and colleagues, wrote that this piece would set the tone for countless teaching sessions in the years to follow. So Bal would soon travel to London to learn from Dr. Saunders and to begin what would become a long and consequential friendship. Returning to Montreal, he set about laying the groundwork for a hospital-based hospice service to care for the dying. And it was through his search for a name that could appeal to the francophone of Quebec, for whom the term hospice brought to mind, as he wrote, neglect in the warehouse-style nursing homes, home shabbiness of les hospices in France, that he landed on the term palliative care. I think he said it happened in the shower. Palliate, a word derived from the Latin pallium, or cloak, had over the centuries evolved from a connotation of concealment to one of mitigation, to make less severe. And with another palliative care physician, Michael Kearney, Dr. Mount would articulate some of the most important ideas about healing and its importance in palliative care. Their thoughts on healing emerged in part from their thinking about the importance of spirituality, which the Oxford English Dictionary defines as relating to or affecting the human spirit as opposed to material or physical things, or having a relationship based on a profound level of mental or emotional communion. Healing, they would write, is a relational process involving movement towards an experience of integrity and wholeness, which may be facilitated by a caregiver's interventions, but is dependent on an innate potential within the patient. A relational process, an experience of integrity, and an innate potential. And this relational aspect of healing was evident in a story he tells of a patient, Joyce, a woman in her early 40s with advanced abdominal cancer, whose profound distress in the face of massive fecal incontinence led her to cry out for euthanasia. And Dr. Kearney led her in a guided meditation. "You are enjoying the warmth and the swaying grass and flowers as you walk down the slope toward the river's edge, where standing by the water, you encounter someone who knows you and who cares deeply about you. The person may be someone you know well or someone who's unfamiliar, but you know the person to be wise, someone who knows the river well, someone who's able to guide you safely in the next stage of your journey. He went on to suggest that there was a little wooden rowboat tied at the riverbank and that the guide was offering safe passage across the river. You know that you are with someone who knows the boat and who understands the river. You do not know where it will bring you, but you do know that you're with someone who knows the way there. You've done all you can. Let the river carry you. Allow this experience. Allow yourself to be carried away. Joyce opened her tear-filled eyes and recalled having met her husband. He said he was with me and that we would be together. She needed no further medication and died the next morning surrounded by her family. So if Dame Cicely brought attention and sophistication to our understanding of the nature of suffering at or near the end of life, I believe that Dr. Mount and his colleagues brought greater attention to the phenomenon and the possibility of healing. That is to say, if total pain was the first radical idea at the heart of palliative care, then the second was the idea that healing is possible through the course of serious illness on up to and beyond death itself. Paradox, Dr. Mount wrote in his memoir, at the end of life, in the setting of crippling decline, it is possible to encounter healing and a new experience of wholeness. It is possible to die healed. The potential for healing through competent care, coupled with the healing potential of an I-thou relationship, the bonding that occurs when we are present to self and each other at the deepest level, continues to astonish me. Palliative care, continues, is the practice of presence, something I had a chance to talk with the pediatric palliative care team about this morning. So in the nearly 50 years since the opening of the palliative care unit at the Royal Victoria Hospital in Montreal, we've witnessed the dissemination and the professionalization of palliative care. And while it continues to be misunderstood by many, community members and clinicians alike, an ever-expanding evidence base suggests the benefits of palliative care and the models by which it can be delivered. In addition to the efforts by hospice advocates and radical clinicians inspired by the work of Dr. Mount and Saunders, I believe that one of the events that enabled the growth of this field was a shift in the dialogue about suffering. In 1982, a physician, Eric Cassell, published a landmark article in the New England Journal of Medicine. It was called The Nature of Suffering and the Goals of Medicine. In it, he drew attention to medicine's failure to attend to suffering and attempted to reframe the redress of suffering as its most important goal. He begins by seeking to address what he called a modern paradox, that even in the best settings and with the best physicians, it is not uncommon for suffering to occur not only during the course of a disease, but also as a result of its treatment. And the genius of his sentence is in its subtlety. He appeals to the arrogance of the profession, even in the best settings and with the best physicians, while sneaking in its core indictment that suffering also occurs because of how we treat people. And I bring this article to light because it reinforces some of the ideas articulated by Dame Cicely and Balfour Mount, and also because it made a discourse of suffering more prominent in the halls of medicine. What's striking is how much it reveals about medicine's blindness to the obvious, and how far astray it had come from the teaching of one of its most famous teachers. For instance, William Osler, once of McGill, said that it's much more important to know what kind of patient has the disease than what kind of disease the patient has. So first, Cassell makes the point that suffering is experienced by persons. In saying so, he was offering a critique of the distinction between body and mind that was central to medical practitioners' view of themselves as purveyors of an objective science. That is, medicine's primary concern with disease, the physical body and that which could be objectively observed, was incompatible with the reality of suffering, centered as it is in people and their objective experiences. The distinction between body and mind delegitimized the subjective experience as being of the mind and therefore less real. And he was asserting that suffering is real and that our inattention to it as such was in fact a further cause of suffering. And we can all imagine this because there's nothing worse than being told when you feel unwell that it's just in your head. Second, Cassell linked suffering to a sense of impending destruction and suggested that it continues until either the threat of disintegration is past or until the integrity of the person can be restored in some other manner. And here, both echoing and I think ignoring Dave Sisley, he writes that although suffering often occurs in the presence of acute pain, shortness of breath, or other bodily symptoms, suffering extends beyond the physical. He pointed out that one can be in pain and not suffer, and one can suffer without pain. He goes on to articulate somewhat poetically the ways in which all aspects of personhood, the lived past, the family's lived past, culture and society, roles, the instrumental dimension, whatever that is, associations and relationships, the body, the unconscious mind, the political being, the secret life, the perceived future, and the transcendent dimension are susceptible to damage and loss. In short, just about everything. Cassell also writes, albeit briefly, about the importance of meaning and transcendence. Suffering is reduced, he notes, when it can be located within a coherent set of meanings. That is, when we identify and associate meaning with either its cause, its effect, or both. And of transcendence, he says that the most powerful way in which one is restored to wholeness after an injury to personhood. Here, Cassell makes a nod to the potential for healing. Persons, he wrote, are able to enlarge themselves in response to damage so that instead of being reduced, they may indeed grow. So it is with the loss of relationships, loves, roles, physical strength, dreams, power. The human body may lack the capacity to gain a new part when it is lost, but the person has it. I think this is so beautifully said, but he is on the whole vague in his description and emphasis on meaning and transcendence. This paper and the book of the same title that followed in 1986 had, I believe, a profound effect on medical care, particularly for those with serious illness for whom suffering was so acute. And if there's evidence to suggest that this may be true, it is the subsequent attention to suffering in the medical literature. This graph shows the emergence of the term suffering in titles and abstracts in the body of indexed medical literature. Now, I've been critiqued on this slide by someone who said if you entered pizza into the title and abstracts of PubMed, it might look something like this also. But I think that what's more important is the gap before 1982 and what people were talking about. Empiricists, so this may be true as far as trends go, but I believe you can see that suffering, despite its importance to people and despite the degree that it is the primary reason for people seeking medical care, has not been long in our academic sites. And for many clinicians, Eric Cassell served as a call to arms and fed a movement to stamp out suffering. In a concurrent development to the heightened attention to suffering, and perhaps to some degree because of it, palliative care started to gain legitimacy as an academic discipline. To be sure, Sisley, Saunders, Balfour Mount, and their colleagues understood the importance of applying rigorous scientific methods to understanding not only the need for their services, but also their impact on people's lives. They developed tools to support the expert assessment of suffering and therapeutic protocols to alleviate it. This was evident in the explosion of literature on the topic. The first paper mentioning palliative care was in 1976, one of 4 that year. Balfour Mount was an author on all of them. By contrast, in 2021, so you got a good argument for naming something, putting it in the literature. By contrast, in 2021, there were 4,275 papers published with palliative care included in the title or abstract. There emerged hospital-based consulting services and specialized units to care for the dying. And this graph illustrates the rise in hospitals with palliative care programs over a 10-year period from 2000 to 2010, from just about a quarter to over 2/3. And now we know that it's more than that. Over 1,000 hospital-based palliative care programs were created in that time alone, in that 1 decade. And 90% of the US National Cancer Institute accredited cancer centers had palliative care teams by that time. Of those, 92% reported having an outpatient palliative care consultation team, and almost 60% reported having an outpatient palliative care clinic. Inpatient and then outpatient. So of course, in 2010, as I again talked about yesterday, palliative care gained increasing attention with the publication of another landmark publication in the New England Journal of Medicine. Jennifer Temmel, an oncologist, and her team at Massachusetts General Hospital described findings from a study in which they randomized 151 people with newly diagnosed metastatic non-small lung cancer to either early palliative care integrated with oncologic care or standard oncologic care alone. The patients in the early palliative care group had better quality of life, fewer symptoms of depression, and received less intensive end-of-life care, meaning fewer hospitalizations, ER visits, or stays in an intensive care unit. However, the finding that caught everyone's attention and just thrilled the palliative care community was this. On average, patients in the intervention group lived 2.5 months longer. The important message to be drawn from this was not that palliative care made you live longer, rather that it didn't shorten your life, which is what people feared and still fear. And in this way, this paper represents a seminal endorsement of the expertise that palliative care clinicians had cultivated in the care of people affected by serious illness, and showed how it can be applied with clear benefit earlier than just at the very end of life. In 2012, the World Health Organization published a definition of palliative care, an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. In theory, there's nothing wrong with this story. It's a wonderful story of two visionary leaders inspired by the care of the dying, or care of the dying, who articulated a philosophy of care, imagined new settings in which it could be provided, and kicked off a half a century of innovation and growth that not only built upon our attention to suffering, but developed entire teams and pharmacopoeia to address it. And I think it's more complicated than that. The picture that I'm trying to paint for you is one in which the narrative of suffering has become more important in palliative care than the narrative of healing. And while one would be foolish to critique the relief of suffering as an important goal of medicine, I wish to suggest that it has its limitations. I would assert that our attention to the suffering of patients and caregivers has proved a critical but insufficient focus for those who care for people affected by serious illness. As much as it revealed, our focus on suffering may have taken away our attention from an outcome of equal or perhaps even greater importance. So consider the metaphor of a garden. I'm not much of a gardener myself, but I've pulled my fair share of weeds. Weeds sap nutrient from the soil and inhibit the growth of other plants in the way that suffering and its precipitants threaten our well-being. Attending to the relief of suffering is akin to pulling weeds from the soil, a laudable but insufficient goal for the gardener. Weeds almost always grow back, popping up in another location, or if we fail to get to the root, right back where they started. The negation of suffering does not promote healing. The removal of a negative is not a positive. No garden will grow without attention to the soil, and if we each carry the seed of healing within us, as Balfour Mount suggested, how do we nourish them such that people have the chance to transcend their suffering and experience healing? I believe that part of the answer to this question is as old as healthcare itself. Why, when ill, do we seek the counsel and presence of another? I would propose that it's because we make sense of our worlds, inner and outer, through our relationships with those around us, or above us, or within us. Some of the relationships are with entities that can't be seen but are believed. Others are with those we love. And still others are those whom we trust to resolve our dis-ease, or at least hope we will accompany them along the way. And if we hold healing as an important outcome of our care and recognize the importance of healing, of finding or creating meaning through our illness experience as a precondition for achieving it, then we will find that it is more often than not, if not always, relationships with others that provide the source of meaning. Healing, as Balfour Mount said, is a relational process. Cicely Saunders wrote that you matter and you matter to the end. The thing about mattering is it only occurs in relation to one another. You matter to me, I matter to you, we matter to each other. We have, even in some quarters of palliative care practice, confident in our specialty, allowed ourselves to believe that our procedures and protocols, our medications, and our mental health interventions are sufficient to address the suffering of those who present to us. That milligrams of morphine are more important than the meeting of minds between a clinician and those who seek our care. And when that is true, I think we fail our patients. It is in fact through our presence, our relationships, that we hold the key both to the amelioration of suffering and the promotion of healing. Balfour-Mount, again, wrote that what we're trying to do in palliative care and all medical care is establish healing connections to be experienced by those who are ill or dying and their families. How can we promote these connections and the relationship, and what might be the impact for our healthcare systems and those who interact in them? First and foremost, I think we have to learn to recognize them, attend to them, and not, as we often do, dismiss them. Healing relationships are characterized by a mutual openness in which clinician and patients alike allow themselves to be seen through the gentle act of caring. The vulnerability inherent to such openness is unavoidable for patients. Everything about their experience, from uncertainty of outcomes to waiting rooms to hospital gowns, reinforces this. Healing relationships also require clinicians to be vulnerable. An openness to being seen as one's authentic self creates opportunities for connection that contribute to meaning in the illness experience for patients and meaning in work for those that care for them. This is a key factor for addressing burnout. Recall the anonymous nursing student. If you really care, would you lose so much of your valuable professionalism if you even cried with me, just person to person? Second, healing relationships must become the focus of our teaching. They've gained insufficient explicit attention in medical practice and education. Medical schools have realized that science degrees and medical entrance exam scores may not best or solely predict physician quality, and have therefore changed entry requirements to include more humanistic skills and values. And this has paralleled a movement towards more humanistic teaching. However, the socialization experienced and replicated in medical education leads many to miss or dismiss the sensation of connections that are familiar to clinicians, often marked by a physiologic reaction, such as gooseflesh or a chill, by an immediacy of awareness of the patient's situation, as if experiencing it from inside the patient's world, by a sense of being part of a larger whole, and by a lingering feeling of joy, peacefulness, or awe. As the physician Anthony Suchman wrote of such connections, such moments seem to be therapeutic for the patient and the clinician alike. It's true that we're more likely to feel a connection with people who look like us. That's perhaps nature. And yet I would propose that in addition to improving the quality of care and mitigating burnout, that our attention to healing relationships can drive equity in healthcare also. Discussions about how to address disparities and improve equity often focus on addressing well-founded mistrust of clinicians or systems, or improving access to services. And certainly ensuring access to the standard of care for all people is critical. However, what does it mean to improve access to systems that perpetuate mistrust by failing to see people as they are and fails to understand the challenges and motivations in seeking care? Healing relationships may help people who have been historically marginalized to feel cared for in ways that foster trust and make access meaningful. To be seen, heard, and understood by one and connected to one's clinician is a powerful rejoinder to the blame and shame commonly experienced by those who do not often fit straight white male norms from which our medical evidence is derived. I would like to believe that our attention to healing and to relationships that promote it might both mitigate suffering and minimize the fear with which people approach the end of life. My hope is that through our expert and multifaceted care and our attention to relationships, ours with patients, theirs with the other people who matter most to them, people will find opportunities for growth and meaning in their lives until their natural end. And that we live in a society that values this time and puts the human and structural resources in place to back it up. Unfortunately, we're not there yet. Before she died, about coming on a year and a half ago, I asked a patient, Jeannie Boulanger, if I could write about her. She was a professor of literature at a local community college, and she expressed feeling touched that her story could be instructive for others. She and her husband, Pierre, warmly agreed. She was 55 and had an early stage but aggressive ovarian cancer that, following a difficult first treatment, left her unwilling to try further interventions. She presented to me in clinic some weeks before she died in the most profound distress. She was racked with pain, doubled over, crying out in despair over her discomfort, asking to die. She had not had a bowel movement in 2 weeks. She presented with the kind of discomfort that makes us take a deep breath to fortify ourselves before we enter the room. And when faced with such anguish, it can be hard to know what to do. It's like a pot that boils over on the stove. How do we contain it when we can't remove it or turn off the heat? And as is so often the case, our attention to and acknowledgement of her emotions gave us some room to breathe, to talk. Our reassurance that we could make the pain better and that we would at the same time help her access medical aid in dying brought some relative calm. What was behind her suffering? Part of it was the pain, certainly, but the bigger part of it was that she felt she could not access the things that gave her a love of life: watching films, reading, writing. I learned that she loved American novels, and in those moments of calm, in the shadow of her total pain, we connected. We left the room with a plan that I hoped would help treat her pain and regain her focus, such that she could enjoy the things that she loved, such that she would not want any longer to die. And I expressed this hope to a medical student with whom I was working, who also felt deeply touched by our patient's despair. The next day, having followed up by phone to find that she was not feeling better, we had admitted her to our palliative care unit in Montreal. And with expert medical and nursing care, her symptoms were brought under control and much improved. And she persisted in her wish to pursue medical aid in dying for reasons that struck me deeply. She told the team that she worried about recovering her ability to do some of the things. Oh, the internet. She told the team that she worried about recovering her ability to do some of the things that she loved, because then she would be faced with the prospect of losing them again. It reminded me obliquely of the expression that it is better to have loved and lost than never to have loved at all. And yet for her, to love something and lose it twice felt unbearable. I had the privilege of caring for her again in the hospital the following week, and we discussed literature and the insights it gave us into suffering. She talked about Dostoevsky's Notes from the Underground, and I shared with her similarities in Virginia Woolf's On Being Ill. I couldn't help but feel that these moments were precious to both of us. She returned home at the weekend on a pass. She felt it was the greatest gift to be able to do so in advance of her scheduled appointment for medical aid in dying for the following week. And when I saw her on the day that she died, I went to say goodbye and to ask for her permission to share her story. She recounted that her trip home had been difficult, that she'd lost her ability to walk. This gave her confidence in her decision, and she expressed peace with it. Bless her partner who accepted the decision with grace, despite the pain of losing her. And as I left the room, aware of the palpable surreality of the moment, I inadvertently compounded it by saying something that would later cause me a brief moment of shame. See you soon. So why do I share this story? Some might say it undermines my premise that connection reduces suffering and promotes healing. And it's certainly true that I hoped that Professor Boulanger could, through our care, access again the things that she loved, such that she would want to continue to live. And this was unexpectedly, for me, confounded by the overriding desire not to lose them for a second time. But I tell the story because it provided yet another example of the power of connection and relationships in our work. We were in each other's presence 3 times. And yet each meant a great deal to both of us. The opening of that relationship was our ability to sit with and engage in her profound suffering. That we heard her suffering and endeavored to understand it was, I would assert, healing. In medicine broadly, and even in palliative care, we too often dismiss these connections despite the meaning that we draw from them. Our attention to and ability to form them enable us to do our best work, even when the outcome is not what we would expect or hope for. Thank you. So I think there's some time for questions, probably.
So for those of you on chat, on virtual, I have the chat open, so you're welcome to either come up to me and ask me a question or put it in the chat and I'm keeping track of it.
So I'm gonna stop, should I stop sharing this, or will it,
Okay.
So I'm in the pulmonary medicine,
yes.
and I've received increased research studies in that OHSU. And a lot of our doctors go into patients' room when they're in ICUs and enroll patients into our intervention studies. A lot of the time they tell me it's like when they go into patient's room, patient just wants to be like talked to and be treated as if they're just being human beings, not as a patient. So
Yes.
I definitely agree with what you presented about the connections and then.
Thank you. Yeah.
So say thank you for really just helping to show us where we've been and where we need to continue to go. And the beauty of this is just the power of presence. I think there's been so much coming out about the construct of creating holding spaces. And even in your story about your patient, but like these three distinct periods of time when you put on that space with her to walk the march towards convention of life. And I'm curious, because a lot of the work that we're trying to do now, like based on what I'm sure Jennifer's telling us, really helping us to now, like in like palliative care 3.0, actually start to define and measure how we do that and the outcomes that it impacts. So I was curious if you could share, you know, your palliative care unit in cases, you know, there's these like palliative care units of how do we, you know, measure and show the power of creating these living spaces to stakeholders and others that are just these wonderful stories, but also in measured fashion and help us to kind of continue to try and feel forward. Yeah. So there's also some questions about what's in the palliative care job.
Yeah, that's in the syringe, it's in the job.
Yeah.
Yeah, exactly.
Yeah, here's your thoughts.
I think there's something that goes unmeasured in the studies about what palliative care does. You know, when you look at the studies, like the follow-up studies on Jennifer Temmel's study that trying to understand how people spent their time, what they talked about, what they did. It's very mechanistic. You know, we've boiled it down to advanced care planning, coping, you know, preparing for the future. And I can't help but think that there's something that happened there that we're missing. We haven't measured it. And so I'm really actually interested in how we measure the quality of relationships as an outcome of care, as a mediator of our outcomes, you know. And I think so. Yeah, I think we have to figure out how to do that. I don't know the answer. We're doing a review now of all the measures that have been used to measure patient experience to try to understand what are the relational items in those instruments and how do they fall into categories that relate in an empiric framework of what a relationship is, just so we can sort of understand, like, how are we doing this now? You know, what are the pieces of the puzzle that we may not distinctly be paying attention to that get developed in the context of a measure of shared decision making or broader patient experience but is clearly about the quality of the relationship. And so you know, that leads me down a path which I never want to go down, which is building measures. As a scientist, that's the last thing I want to do. But I think, as has happened for many people who end up building measures, is they find themselves in a place where they don't know what else to do to measure this thing that's not measured right now. And so, you know, this is work that I think that I would like to sort of lean into a little bit in the next few years, is trying to figure out how to measure relationships, because the quality of relationships as they're perceived. Because I think without that, we can't, you know, we can say that advanced care planning is 20% of palliative care, you know, thing that we do, right? And we can teach people skills to engage in advanced care planning. I think we've learned that we're vulnerable to attack on that front about what advanced care planning is, even from within our own ranks. And there's also something like, I don't know, there's something deeply unsatisfying for so many about the practice of medicine now. And to me, like, this is the way that we restore that thing. Like, we're so lucky in our work in palliative care to, I think even if we don't talk about it explicitly, we recognize the value of the relationships that we form with patients. I mean, pediatric palliative care is a specialty built on the most, on leaning into the development of relationships far more even than in adult palliative care, right? And yet we don't talk about it much. And so, and I don't know, because it leaves us vulnerable in some ways, because the way we think about relationships in our life. I mean, Taylor, we were talking about love this morning and the risk in talking about love because of the way the associations we have with it, and relationships may not be so different. So, when I think about teaching relationships or measuring them in some way, like I think about this quote a lot about, these sensations, these bodily sensations of having a connection with a person. And these are familiar to all clinicians. I know they're familiar. And it's true that, we're more likely to have those with people who look like us, as I said. But it doesn't mean that we don't have them with others. And I think that what our skills lead us to in palliative care is to places where we're more likely to have those sensations with people. I have them all the time. And I don't think it's just me. Like, I was talking with the pediatric group this morning about how often, in reflecting back to someone the things that they tell me about what's important, I feel the chills that he's talking about. And they feel it because the tears well up in their eyes, and like there's something going on here that's really powerful. And we need to lean into that and teach people what that feels like. I mean, we don't need to teach them what it feels like. We just need to teach them that that's a measure of good care potentially. I think where it has to come along with more discussion about boundaries, which is something I didn't even learn about until I was a palliative care fellow in any meaningful sense. Because with vulnerability, there's risk. And it doesn't mean, as I often say to my trainees, and I think I've said everything I know in the last couple of days, probably more than once to different people. So now I forgot it. So anyway, that doesn't matter. I don't have to say it. It'll come back to me. Oh, I know what I was going to say. It's important to recognize our boundaries, not because not so that we don't ever transgress them. Sometimes taking care of a person requires that we transgress boundaries that we wouldn't typically do. And we just have to recognize when it's happening, because if we don't, then we leave ourselves vulnerable to burnout and other things. And that's having the opposite effect of something that that would be an adverse effect of having a relationship, potentially. Your question.
There's a comment and a question online, so I'm going to go to those quickly.
Okay.
A colleague shared what a profound and enlightening talk. Some of us may not be aware that 2 decades ago, I was a medical student at the University of Vermont, where I was on faculty. While he's about as far from Darth Vader as I can imagine, in this case, Justin would be right to quote the Sith Lord.
I'm really curious where this is going.
When I left you, I was a learner. Now I am a master.
That's very kind.
Sorry about I did not do that justice.
That's very kind.
And then Rika had raised her hand. So Rika, I would love for you to come off mute and answer the question.
Katie, and thanks for is my audio okay?
Yeah, I can hear you. Yeah.
A little weird on the website. One question I had in hearing the latter half of your talk is we do a lot of team-based. I'm over at the VA, one of the palliative care physicians over here, and we talk a lot about group dynamics and do a lot of team-based visits. And I'm just curious about in terms of healing relationships, what your thoughts are on group dynamics versus individual dynamics, and if you have any other maybe insights or research-based findings on that. Thanks.
Thank you for your question. I want to clarify, do you mean like the relationships that we have with each other or the group relationships we develop with patients, or both?
Yeah, thanks for clarifying. I was thinking more the group relationship, like palliative care team relationship with patient as a team versus individual relationships. Yeah, curious about any of them.
Yeah, well, I think it would be foolish to suggest, based on my own history and evidence, that like we're all equally capable of having the equal quality relationships with all people. There are ways that we connect with people in our lives for reasons that we cannot understand. I mean, and I think to deny that would be just illogical. I don't understand some of the relationships I have in my life, the ways in which I connect with some patients more than others, no matter what their background is. There are just some people for whom there's connection. You know, what I would hope with, we do everything we can as individuals to connect with patients, to build those meaningful connections in those relationships. And the importance of having a team is that there's always you're more likely to have someone on that team who makes a connection that is really deeply meaningful to someone based on whatever experiences or innate, whatever it is within them that resonates or fits with that person. I mean, it's interesting. We talk, my wife's a developmental psychologist, so I hear a lot about really interesting things with children. She often talks about fit, between a parent and a child, and it's true between humans. Like some of us fit together better for reasons we don't always understand, irrespective of the sort of superficial commonalities that we might bring to the equation. Although sometimes we have to attend to that also. But I think as a team, we need each other in part as a team, and the relationships that we cultivate as a team for our own sake, right? Because you can't, as my mentor Susan always said, never worry alone. And we have a lot, we're human, so we worry about things, and we have difficult situations that we need to process with each other, and the sort of micro and vicarious traumas of caring for people who are in profoundly difficult situations. We need each other to do that. We need the relationships with each other. But we also need teams to expand the sort of relational capacity that we have vis-a-vis one individual person or their family, or because we rarely treat one person alone. The family or chosen family, the entity of people, a group of people for whom we're caring. Sometimes, like, it's amazing when you have when I'm working with when I go into a room with one of my nurse colleagues, and like she's having a discussion with the caregiver on the left, and I'm having a discussion with the patient, or vice versa, and we are creating a relational ecosystem in this room that it requires more than one person, or is certainly benefiting from more than one person. And so there's so many reasons for us to have and expand and nurture our teams, independent of the patients themselves. But I think that that relational capacity that we have as a team is so much greater. Yeah.
This will be our last.
I've been thinking about, Jason, your question for a while, and I wonder if there's a sense where, like, the failures of advanced care planning, everything that's been written about that in the last couple of years, is evidence that we're thinking about the question wrong, which is, could it be that the very act of trying to systematize or turn these human things into science, sort of like the Hawthorne effect, like erodes the practice itself, and that's why we see these problems arise kind of in a cyclical fashion. And I was thinking of this quote. There's this literary theorist, June Torley, and she's talking about. She's quoting someone else, this philosopher. He says, "Today we live in a culture dominated by science and technology. We are prone to think that all serious questions could be answered by the natural sciences." And then she goes on and says, she said, "And I'm concerned by this, that even humanists these days appear to have embarked on a quest to substitute measurement for judgment in every human practice." And I think I first heard that when I was as we were talking earlier, at HPN, where it was like one of these state of the sciences that when you really boiled down to what it was just like trying to talk about people talking. And so I don't know, I see it as like kind of an opportunity for our field
Yeah, I mean,
those dimensions.
it's a really tough issue because, you know, to the extent that that medicine is lent into this sort of realm of empiricism as a way of gaining legitimacy in a scientific enterprise that is sort of formed in a sociological universe, you know, that in a historical frame that we, you know, that others have written about really beautifully, like Paul Starr, for instance, like the quest for legitimacy as a human is something that we embody as a field, right, in some way within a broader entity. You know, we're trying to get traction in some way. And I think it's important, one of the reasons I wanted to talk about this today, and I talk about this with palliative care people, is because I think it's really important to us to hold on to the historical center of gravity of our field. Like, where did we come from? I think if we know that, it helps us to some degree hold on to this and make sure that we're trying to measure the right things. Because I think that it's easy for us to get led astray into measuring things that don't matter as much. At the same time, like, I think we can use science to our advantage to help change clinician behavior. So for example, as much as I, you know, would lean into things like palliative care being the practice of presence and really want to cultivate this sort of spirit of palliative care and share that, you know, I'm also doing work in virtual reality to try to understand the proximal emotional and cognitive impact of communicating prognosis in one way versus another. Because one of the things that I encounter as a teacher is that it's perfectly reasonable for an oncologist to say to me, why should I not communicate about prognosis using median survival? And to me, it's obvious because median survival for any one person means nothing, zero, zilch, right? And yet, and I think, because based on my own experience, that using different language to communicate prognosis is likely to be more useful to people. Even if it feels less precise in some way, although as I said, there's nothing precise about a number that means nothing to a person. And yet I want to do this work because I want to engage in this sort of measurement work of science, because I want to be able to say to people, don't do it this way. And this is the language they speak, you know? And so, because if I can say to people, this is not, what you're doing is not evidence-based, then there's the likelihood, you know, certainly we train people in communication skills. Many of us in this room train people in communication skills and they get it. They're like, aha, yes, I get this. This makes much more sense. But there are those people who are looking for harder evidence of what to do and how and why, that we need to, I think, meet where they are to some degree. And so I think if we have to hold this tension though, because what you're highlighting is a tension, and I think it can't be all of it. We can't just say science sucks, right? We have to engage in it in some way, even though we know that it's imperfect and it's limited in what it can teach us. So that's how I think about that. It's a dance. Thank you all very much.
Thank you all for coming to these workshops and sending that in now. Thank you.